Good afternoon. Right, good afternoon to everybody who's tuned in for the session this afternoon. My name is Stefan Hofmeyr. I am at Tygerberg Hospital in the University of Stellenbosch. Welcome to this Gastro Foundation Echo session in association with Project Echo from the University of New Mexico, and also for the technical help from the Echo India team. So the topic this afternoon is bile duct injury. So obviously, before I start, I'd just like to plug the IHPBA Congress in 2024. Please, whoever you speak to from an international audience, make them aware of the Congress. It's the first time that this massive meeting will be on the African continent, and we're working hard behind the scenes developing the program and hopefully making it a very successful event. So bile duct injury, unfortunately, is not uncommon. That's why we're discussing it this afternoon. If you think about this, it's more important to avoid it than to try and fix it. It's so important to try and avoid and recognize this and give patients good outcomes, because this has an extreme effect on a patient who this has happened to, his life going forward, as well as the surgeon involved. I think the effect on the surgeon is obviously something that we underestimate. So we'll go through this talk in terms of trying to avoid this, recognizing it, and treating the patients, and ultimately ending up with a definitive repair. So the problem is actually quite a large one. If you look at developed countries where the data is trustworthy, in the USA, there's, depending on what you read, up to 500,000 cholecystectomies per year, and something like the UK, about 60,000 per year. So because it's such a common elective operation, if you quote a normal figure of 0.4% of biliary injury during cholecystectomy, you end up in a country like the USA with up to 640 biliary injuries per year. Now, obviously, if you look at the data, some of these are bile leaks and some of these are massive, major injuries that would require repair. Now, if you perform a cholecystectomy laparoscopically, it's not just the bile duct that can be injured. So other injuries can also occur that also confuse the post-operative state. But in any patient whose course deviates from the normal, where there's any unexpected pain, or for instance, a post-operative ileus, or a patient that you just can't discharge on minimal analgesia, these patients, a biliary injury should always be expected. But you can get injuries from the duodenum that sometimes has to be mobilized off the sick gallbladder as well as the colon. Just by placing the ports in a patient who's had previous surgery or performing adhesiolysis, you can injure other structures, especially possibly some very proximal part of the small bowel, which could lead to a biliary type effluent in the drain in the post-operative period. But usually these injuries declare themselves as patients with bile leaks. But you can also have some extreme injuries like vascular biliary injuries, where patients become extremely ill afterwards and have hepatic failure. Or patients, for instance, can become jaundiced due to other causes, such as a missed stone that stays in the bile duct. So in research that we published in the essay in the South African Medical Journal in 2015, there are more or less two scenarios in which the bile duct can get injured. One of these scenarios is in a purely elective state, where a patient might be diagnosed by a general practitioner with an ultrasound with symptomatic gallstones. They are kind of chronic cholecystitis, where the area in the hepatoduodenal ligament is easy to dissect. The tissues are still supple, and as you withdraw the gallbladder neck towards the patient's right hip to open up the callow or the hepatocystic angle, basically the bile duct is pulled into the area of dissection. And if you start your dissection in the wrong place, it's very easy to injure the bile duct and cut a part of the bile duct out. That is the classic injury in a patient who doesn't have a scarred hepatocystic ligament. So in this data, 80% of patients had this kind of injury, whereas in 20% of patients, there is chronic cholecystitis, which has scarred the hepatocystic angle, or you're operating on a patient with acute cholecystitis. And in these types of injuries, the surgeon already has his alarm bells ringing, and it is possible to not dissect safely And so in these patients, it's not a misidentification or a problem of starting too low. It's purely that the dissection is difficult and is hazardous. So those are the two scenarios which to keep in mind when you're doing these operations. And I think it's critical for all of us, even if you're an HPV surgeon, but that we always aim these, avoidance and advocacy of safety against a bile duct injury during cholecystectomy at the wider general surgical audience, and that we always try and advocate, for safe cholecystectomy by getting people to follow the right steps during these procedures. If one thinks of this critical view of safety, which was published a long time ago, and which is kind of like the standard of care of doing a laparoscopic cholecystectomy, the important parts of this are three elements. And I think people sometimes forget the third bullet point, but that you should clear the contents of the angle by separating a wide angle out and clearing the fibrofatty tissue towards the hepatoduodenal ligament. But during this stage, you then want to end up with two structures only entering the neck of the gallbladder, which are the cystic artery and the cystic duct. But that is not enough. If you've opened up a small angle and displayed these two structures, you should still separate enough tissue out so that you end up with this type of picture where the bottom of the gallbladder has at least partially been safely dissected off the cystic plate, which is where the gallbladder attaches itself to the bottom of the liver. This area has to be open a little bit, and that is to make sure that whatever tissues are going back towards the liver do not contain any aberrant bile ducts like a 6 or a 7 bile duct that actually will be recurrent, or a right hepatic artery, a so-called caterpillar hump that has been pulled into the angle, and this is then what you are trying to avoid. So this is what you end up with, a critical view of safety. But in essence, to get to this view, patients have to have what I call dissectable anatomy. You have to have a friendly environment in which to dissect. But in actual fact, quite a few of the patients that we end up operating on, and this is true for most, for anywhere where you do cholecystectomy. Some patients might have been symptomatic for a very long time, might have had ERCPs, might have had repeated episodes of scarring of their paracystic angle. And in these patients, the critical view of safety is not appropriate. So a critical view of safety is where you want to end up. But you cannot at all costs try to dissect towards the critical view of safety. There has to be a place where you have to realize during an operation that this hepatocystic angle is so fibrosed or is so inflamed that I cannot, with safe dissection techniques, whether you usually use the Maryland dissector or the hook dissector, that you're not able to open up the critical view of safety. Then you have to abandon the attempt to get to the critical view of safety. And that then is what we call an inflection point, where you have to recognize the danger of further dissection, and you have to be able to bail out of trying to get to the critical view of safety. Now, the stopping rules where you have to stop is when you cannot get a safe view established with a safe technique like sucker dissection or blunt dissection, when you have identified more than two structures entering the gallbladder itself, when there's an unusually large cystic artery, or you see large arterial pulsations behind the presumed cystic duct, you are actually dissecting the common bile duct. When there's a large ductal structure that disappears behind D1, it's called you're flying too low. So whenever you can see the duodenum during a laparoscopic cholecystectomy, you should be thinking, am I not dissecting in the wrong place? When you cannot apply a medium or a large clip over the cystic duct, it might be the common bile duct. When there's excessive tissue, so you're dissecting and dissecting and dissecting, but you're not getting the angle open, it's because you're operating right through the hepatoduodenal ligament. When you see an intact gallbladder, but there's bile leaking during the operation, and when there is a transfusion required for bleeding, you should have stopped a long time ago. So I'm saying this, I'm preaching to the converted here, but this is what we usually try and teach people who are starting off with cholecystectomy. But this is something that experts should know, so that when somebody calls you, you know that you should be able to tell them to stop. So when you come to these inflection points and you're starting to think of bailing out, you must think of what help you have available, what kind of center are you working in, because it might be appropriate just to pull everything out, put a drain in, and stop and refer before further damage is done. Can you perform a cholangiogram safely at that stage, especially to diagnose an injury that might have already occurred? Cholecystostomy might be a bailout technique, but the thing about a cholecystostomy is that it's not, it's not a way that you are treating definitively the indication for the operation. And to my mind, conversion doesn't fix if you've been unable to dissect the hepatocystic angle. If you do a conversion, it's not all of a sudden going to make it possible to operate in the hepatocystic angle. You're going to face the same difficulties in an open operation. So I try to teach my fellows and my trainees to try and move away from converting to open surgery, and I'll tell you now why. But so the bailout technique to me that usually becomes the most attractive is that you should be looking at being good at subtotal cholecystectomy. And quite often, if you're the HPB expert in your hospital and you're going to get called to a difficult cholecystectomy, this is the one that you should be good at in terms of trying to complete the procedure and avoid a violent injury. So if you look at the Tokyo guidelines of I think it's 2018 or 2017, the surgical managements during acute cholecystitis, the options that you have are open conversion. To my mind, the indications for open surgery are when you cannot find the gallbladder laparoscopically, you should open to try and go and find it and do the operation, because that's not something that an expert all of a sudden might be very good at, and that you should convert for when a patient is bleeding massively, or when you have already caused an injury and there's now a repair that needs to happen. Those might be reasons for converting to open surgery. But an open surgery in an obese patient, when you have only one assistant, no omnitract, is actually a very, very difficult operation. So if you're going to end up in an open operation of doing a subtotal operation anyway, then I think we should all start being very good at doing subtotal cholecystectomies. Fundus first is given as an option, but fundus first is not actually an easy operation laparoscopically, because when you do fundus first, you might stop being able to retract the liver well. And you would need extra assistance in being able to do that. And if you go too far with a fundus first approach, especially if the cystic plate is contracted due to chronic inflammation, you're going to end up in the right hepatic duct or the right hepatic artery with a fundus first approach. And that is only really for the very experienced surgeon. Whereas I think anybody, no matter, or any surgeon who has some form of laparoscopic experience, can actually do a subtotal operation, because it is actually not that difficult. And the two types of operations that you end up with, and I think this Journal of the American College of Surgeons paper, which is also published by Strasbourg, is actually a must-read for anybody who operates on the gallbladder, especially HPB experts. It's where you open the gallbladder, because when you enter the lumen of the gallbladder, that is actually the safest plane. You cannot injure the bile duct if you're inside the gallbladder. So you might end up with this kind of operation where you just open it and you either then dissect the mucosa away again afterwards, or you could cauterize it, but end up with a draining area. Then you could just put a drain on it. That is a fenestrating subtotal operation. Or if you have the confidence to then suture it closed and you know you're away from the ducts, then you can do a reconstituting operation. And what has made it much easier for us in my hospital to move to to converting to a subtotal operation, because it actually makes everything quite fast again. If you know that you can do a subtotal quickly and safely, you don't spend hours trying to dissect the hepatocystic angle and waste time. So what we do is your usual 4 ports. This is looking at the patient from the right side. This is the operating surgeon's 2 ports. This is for the retraction of the usual fundus by the assistant. And that is the camera port is somewhere in the right iliac fossa. By looking back from the 10mm port close to the xiphoid process, we put in an 11mm or 12mm port and then introduce a bag under the gallbladder, so that when we open the gallbladder, all the mucus and content and pus and stones falls directly into a bag that we can catch during the operation. So that makes the fenestrating kind of operation or subtotal much faster. So in terms of managing bile duct injury, it's important to recognize it. So the steps that we then follow is that we should then first stabilize the patient, and in that stabilization period of resuscitation and kind of saving the patient's life if necessary, there will be some imaging, which will be done for sepsis as well as to delineate the anatomy of the patient. And after that stabilization period, In a patient who is not recognized in the immediate laparoscopic cholecystectomy and is a candidate for an immediate repair, we will then decide whether to do an early versus delayed repair during that initial assessment. And then, depending on when the repair is done, it's important to control bile, whether that is actually done out of the liver or through the abdomen by drains, because that is an important step in avoiding further sepsis. Then we need to maintain the patient's nutrition and fitness, get them to a place where they can actually survive an operation and heal the anastomosis, and then bring them to a definitive repair. And I say repair because most major bile duct injuries need an operation to fix them, bilioenteric anastomosis, but some other interventions endoscopically might become appropriate to fix some injuries after a given period of resuscitation and stabilization. So to recognize a bile duct injury, this can sometimes be very subtle, but I think the first thing is that if you are called as the expert by a concerned colleague, either intra or post-operatively, you should already suspect a bile duct injury. And whatever you tell the surgeon in that post-operative or intraoperative period should be directed towards possibly fielding and giving the right advice for a biliary injury that might have already occurred, or avoiding further injury down the line. So patients declare themselves with something as simple as a biloma that requires drainage, or free bile in a drain that is placed operatively. And I think we should all be very given to placing drains if a cholecystectomy has been difficult. So in any patient where there's been some form of bleeding or difficult dissection, a drain can always be removed in the first post-operative day if there is no bile in it. So patients will sometimes present jaundiced. It might even be a patient that is well for a day or two that has already been discharged. So if you hear anything back from a patient, or somebody is calling you about a patient who had a cholecystectomy a day or two ago, and now the patient is sitting with them and they're complaining of abdominal pain, you should go out of your way to get that patient back into hospital and image them. So all pain should be investigated. A patient who's had a lap chole should not have or be labeled with a post-operative ileus. And we all know that a patient who is leaking a small bit of fluid, an ultrasound or a CT scan can actually be normal in the immediate post-operative period. So a normal ultrasound and CT do not exclude a bile leak. These patients are well with a chemical peritonitis, which could be very subtle. And by the third or the fifth post-op day with this bile leak, they all of a sudden get infection of the bile. And these are the patients that drop dead at home or drop dead in the ward somewhere in the wee early morning hours. And so we should not, ignore these patients. And in patients that I get referred where I suspect a biliary injury, but the imaging is normal, I go and put a laparoscope back and I go and have a look around the abdomen. And if your alarm bells have been going, quite often you see that thin film of bile which is starting to spread throughout the abdomen, and you can place a drain or treat the patient appropriately at that stage. We classify biliary duct injuries still by the Strasbourg classification, but there are some others that a fellow should know of, such as the Hanover classification or the ATOM classification. What they try and do is make up for some of the shortcomings of the Strasbourg classification, such as the time period afterwards, as well as vascular injuries or other injuries, as well as patient fitness are taken into account in these more complete classifications. But because we like the Strasbourg classification still, because it's an anatomical classification, and it really describes the injury that happened in terms of the bile duct that needs an intervention. So although as a surgeon or as the person who's going to look after these people, you should still obviously take vascular injury into account, because that is going to influence the timing of your intervention or some other procedures that you might need to do. But the Strasbourg classification is known to all, and we know that the type A injury is what we just call the good old bile leak, is when the cystic duct leaks, and this is also what happens after a subtotal cholecystectomy. Patients end up with a type A type injury, although it is not a true injury, or the subvesical bile ducts. The Ds are when there is no loss of continuity, but a thermal or a cut injury of less than 50% of the duct, in which these patients, if identified correctly, might undergo endoscopic treatment. Whereas the type B and type C injuries are those where there's an accessory duct, usually a right posterior duct, which has either been ligated, and there are probably more of these patients that we know of that might have had a cholecystectomy that we never ever see, where a small duct is clipped, but because the cystic duct is clipped, these patients might have some abnormal liver functions or minor complaints, but they never develop sepsis. And unless they have a concomitant arterial injury where there will be atrophy of the duct or possible sepsis, if the duct is injured in isolation, these patients might never come to medical attention. Whereas the patients who have a 6-7 duct that leaks afterwards, these patients will end up with some form of biloma and might even undergo an ERCP. And if the cholangiograms are not interpreted correctly, because it's easy for a person who doesn't do this a lot to not report that there are 6-7 ducts that don't show up on a cholangiogram. These are the injuries that it might be difficult to diagnose what exactly the cause of the bile leak is. And then the E injuries, which is where the Bismuth classification has been built into the Strasbourg classification. This tries to show how much of the tissue has been lost below the biliary confluence. And in the end, this describes how difficult the repair is and how likely the patient is to stricture again afterwards, because the more tissue there is to anastomose afterwards too, obviously the better the outcome of a surgical repair is going to be. And when one thinks of, what is a duct of Luschka, I'm not sure, if people still get taught this, but there used to be thinking that there are ducts that drain directly into the gallbladder, but the contemporary thinking is more that patients probably have subvesical bile ducts. So in other words, some of the posterior or lateral segments of posterior segments of the right liver that drain just under the cystic plate back towards the liver are sometimes injured if the gallbladder is taken out when the cystic plate has actually been breached and you're operating in the liver parenchyma to get the gallbladder out. Those are probably what we think of as ducts of Luschka, which then can leak bile afterwards. And those patients can be treated by ERCP. So if a bile leak has been discovered, irrespective of the cause, the priority is to very aggressively diagnose, treat, and prevent sepsis, which inevitably means that the patient will need some form of drain placement in the perihepatic space, especially the right subhepatic area, and will then need a washout to control the leak. And the thing is, this can usually be done by laparoscopy. It is not always easy with a patient who has got bile in all 4 quadrants of the abdomen to do a laparoscopy, but you have to be slow and meticulous about this. And really, I don't think any surgeon who does this laparoscopically will be able to drain all the bile out of the abdomen. I think the goal really is to, in all 4 quadrants of the abdomen, to gently instill saline and dilute the bile, make sure that you've sucked out most of the areas where bile was collecting, and then make sure that you have wide drainage of the right subhepatic area so that the bile can be controlled afterwards. In some situations, it might during that laparoscopy, if you have the necessary experience, to reclip something like a cystic duct or repair the injury. But I think this is, really at that stage, the patient, if a problem has been discovered in the hepatoduodenal ligament or in the area of previous dissection, it's probably mostly appropriate just to place a drain and get the patient to an expert to then at least make sure that there's a cholangiogram available before any other structures are clipped and extra damage has been done. So during this laparoscopy, the message is to drain the bile, control the bile, and not do any further damage. So don't scratch around before you know what the anatomy is actually like. Further management will then be determined by what the actual injury is. So we'll try and give the patient a Strasbourg nomenclature of the actual injury that has happened. Because if it's a type E right through to an E5, that will determine what we do afterwards. And we should be quite liberal with trying to get MRCP for these patients. There's often a knee jerk for a surgeon that has a patient that is draining bile afterwards, is jaundiced, to say, can I send the patient to you for an ERCP? And ERCP in patients with small bile ducts who have a biliary injury, if you compound the situation with a pancreatitis, because it is a difficult ERCP, you really have done the patient no favor. So quite often, if somebody calls me and says, can I send a patient with post-operative bile leak or jaundice to you for an ERCP? I would say, great, send the patient to me, but I'm going to investigate the patient first. And quite often, that MRCP, as we go and speak to the radiologist, listen, we need a quick MRCP, we prioritize the patient. And especially if we use Primavest hepatocyte-specific contrast agent, which is excreted into the bile duct from about 3 minutes after the first views are taken, and then every 2 minutes after that, we can usually try and, in most patients, show exactly what the type of injury is. So MRCP is important before we entertain an ERCP on these patients. And if it is a stone left in a bile duct which has been causing the jaundice, then that's great. But we have to prove that before we subject the patient to an unnecessary ERCP. So if patients have been transected and they are not candidates for early repair, a PTC might be thought of. Or if the patient is for an early repair, in some centers, a PTC will still be done to place trans-anastomotic stents and try to help identify the ducts afterwards. So if the patient has a Strasbourg type A and D injury, once the sepsis is under control and the fistula is controlled, we don't have to do the ERCP the next day. The focus in patients with A and D injuries are really to get a drain to the area of leakage, control sepsis, because the patient is not going to die because they're leaking bile. They're going to die because the biliary leakage or fistula is uncontrolled and there's unresolved sepsis. Once the drain is in and functioning well, we can then chart the amount of bile that a patient leaks per day, replace that with normal saline intravenously, and after 1 week, we can make an assessment as to whether the patient is a candidate for an ERCP. Because quite often after 1 week, if the volume of drainage remains very high, we know the patient needs an ERCP, but quite often, once the drain has been placed, especially if it's a type A injury or the patient has had some form of a subtotal cholecystectomy, you would often see that the drainage in the first 2 or 3 days will be high, and then as the area starts to heal and seal off, the volume of biliary drainage will all of a sudden come down, and the patient will never need an ERCP. So don't just do it immediately. And then as to whether you do a sphincterotomy or a stent or both, that is always a topic of contention. So we talk about high-grade leaks and low-grade leaks. And what I was taught is that if you, after you've done your endoscopic cannulation and you inject contrast into the biliary system, if the intrahepatic ducts fill and then the patient starts leaking from the cystic duct remnant, then you have a low-grade leak, and a sphincterotomy is probably going to be enough. However, if you inject your contrast agent and the bile starts leaking out of the cystic duct before the intrahepatic ducts fill, then then patients usually would need a plastic stent to decrease the pressure within the biliary system and create a preferential drainage route away from the cystic duct for the area to heal much better. So I think in essence, though, most patients will end up with a plastic stent in the bile duct once you've gained endoscopic access, which is perfectly fine. But it's not important to get a plastic stent past the cystic duct. All you're trying to do is really just decrease the pressure in the biliary system for patients to be able to heal. Once the leak has stopped, we probably should remove the stent no later than 6 weeks afterwards, as a 6-week period is the one within which we would not expect a plastic stent to occlude under normal circumstances. But once the drainage has stopped, we would then remove the drain first, let the patient's wounds heal, and once the patient has healed their wounds, then stent removal can be entertained in 1 or 2 weeks after that. You do not necessarily have to wait for 6 weeks. When we talk about major injuries, those that require repair, there has also been a grading of bile duct injuries. So patients with grade 1 are these patients with the minor injuries or the cystic duct leaks, and these patients would expect to have a good outcome from an endoscopic intervention, such as a stent placement. But when we talk about grade 2 injuries and grade 3 injuries, these are patients where an operative solution to the problem becomes more necessary. In a grade B, if these patients are picked up in the early post-operative period, and this duct has significant size, we say usually larger than 3 millimeters, we would entertain an hepaticojejunostomy or cholangiojejunostomy just to that specific area. Whereas with grade 2 injuries, these patients will require an operative intervention to obviously drain that system into a bilioenteric anastomosis. So what I just neglected to mention in the previous slides is in the patient who's been diagnosed with a bile duct injury, it's important to always get a CT angiogram in that initial phase as well, to make sure that we are not missing an arterial injury, which would influence the timing of repair. But then still under grade 2 injuries, there will be patients with some common hepatic duct or the confluence intact, where the left and the right system is still in communication. But when the left and the right system are not communicating anymore, it implies that you would have to do separate anastomoses to these patients' injuries, which will be an expectedly more difficult repair, as well as one where there would be a higher stricture rate post-operatively in the follow-up period. An E5 injury is when a patient has a combined injury of any of E1 to 4 plus an accessory duct which has been injured. So if we talk about the timing of repair, there are various definitions, but the one that surfaces the most commonly or most common is to say that patients will either have an immediate, early, intermediate, or late repair. Immediate, once you've excluded that, an early repair can be anything from 7 to 14 days, and a late repair usually from 6 weeks onwards. So I think the important message is that patients who are between 1 to 2 weeks and 6 weeks after an injury, that these patients are only repaired surgically under very strict circumstances, and it's actually not advised to repair patients in this intermediate period, because in this kind of period, patients would usually have some form of granulation tissue or which has been caused by the sepsis or the bile, during which the operative and as well as the adhesiolysis that you would have to do period, it's not expected that you would be able to have friendly dissecting circumstances and during this time period. So if you then exclude intermediate and you talk about which is better, an early or a late repair, if we talk about better, we say which patients will have a durable repair which is not going to stricture afterwards. It's actually quite a complex scenario. When we talk about bile duct injuries, of course, we're talking about patients in which the physiology is variable, dissecting conditions are variable, the injury, according to Strasbourg, E1 to 5 is quite variable. So it's not always possible to just make a blanket statement where we would say patients should be repaired early or patients should be repaired late. But when you look at meta-analysis where they have broken down patients into this less than 2 weeks, 2 to 6, and more than 6 weeks time period for repair, these meta-analyses invariably will show you that patients who have a late repair will do better. Because what has happened is that in comparison to patients who have had an early repair, there has been some time for patients to actually heal the subhepatic space, get physiologically better, and then operating conditions and tissue is much friendlier, and you can do a much better operation in the later phase. However, I'll come back to that now, but if you discover a patient and you are called immediately in a laparoscopic cholecystectomy, that is obviously the best time to actually fix the injury, because the patient's hospital stay will be shorter. The patient might be much more amenable to not suing the doctor or taking legal action, because they are not going to be in hospital for a long time. So if you can repair a duct immediately, it will probably lead to a much better patient outcome. But the prerequisites for an immediate repair have to be adhered to, and this is that the patient has to be stable and sepsis-free. Only minimal local sepsis is advisable if you are going to undertake an immediate repair. There has to be no significant arterial injury, because the duct is still going to die back a little bit if there was an arterial injury at that index operation. You need a roadmap if you're going to repair a patient. So if you're going to see an injury and immediately just put a loop of small bile onto it, you don't know if you are going to account for all ducts. So you need to account for all ducts, and that implies that you need to do a cholangiogram if you are going to do an immediate repair intraoperatively. Otherwise, you might be missing something like a 6, 7 or a posterior duct, and you're going to do an anastomosis to a duct which is not representative of the whole liver, and the patient will have a very difficult to treat bile leak despite an intact anastomosis afterwards. And it's a given that the repair should not be undertaken by somebody who's inexperienced, or the repairing surgeon, or the repair should not be undertaken by the surgeon who actually injured the duct. They are usually a general surgeon, and their decision-making is affected by all the emotions of the realization that an injury has just occurred. So if we think about 2 slides ago, the early versus late repair debate, invariably there are factors present in the early situation, which might as well be if the patient was not well prepared and the late repair is undertaken. The factors that will lead to a failure or a stricture are those patients who have an anastomotic leak, who have regional sepsis, in patients who are unfit, or if the surgeon doing the repair is inexperienced. So in the early versus late debate, if an early repair can be done, it should be done on a fit patient with no uncontrolled fistula. There should have been no wide leakage of bile before the patient was taken to theatre for the repair, which has caused inflammation. Minimal sepsis, no vascular injury, anatomy has been mapped, and an experienced team is doing the operation. So if none of those factors are present, then an early repair can be done if the patient was discovered soon after the operation and not immediately, has been referred quickly, and all these other factors are taken into account. Then within the first week, we can undertake a repair which is expected to have a good outcome. But once you have controlled bile, once the patient has been rid of their sepsis, most repairs can be performed 6 weeks to 3 months later. There's no reason to go in at 2 or 3 weeks once you have taken into account and stabilized the patient. In patients that develop jaundice versus patients that leak bile afterwards, obviously the patient that is referred day 4 with jaundice, who has a clip on a bile duct and no sepsis, this is a much easier patient to repair than a patient who's had a leakage of bile where drains have had to be placed. And then remember that some patients who present with strictures, they present maybe 3 months, 6 months, or 2 years afterwards. In these patients will invariably have a late repair. To control bile, if it is discovered intraoperatively and the patient is not due for repair, a clip should not be put on the bile duct to try and control the sepsis and distend the system, because it's going to lead to more dissection to possibly place the clip. You could injure something else, and you're going to lose more tissue because the clip has been put on a duct. It actually makes the repair down the line, could make it more difficult. So it's appropriate to just place drains, and sometimes if the surgeon can, a Foley catheter can also be put introduced percutaneously through one of the port sites and be put up into the bile duct so that you can actually drain the bile directly into that, and also have a route to do a cholangiogram after it. So that can sometimes be helpful, and it doesn't have to be fixed to the duct. In the post-operative phase, a well-functioning drain will control the bile very well, obviously, but in some patients, a PTC can be done. But remember that a PTC in a patient who has a freely draining biliary injury is not actually easy, because the bile duct is quite small, and you need a very experienced radiologist to be able to put a PTC in, especially if it needs to be done bilaterally. And sometimes if there's a Foley catheter in the bile, in one of the bile ducts that was placed at the operation, and you can inject bile into the biliary system, that might actually help the radiologist to then do a PTC afterwards. And I think the question to my mind always is, if you have a patient who has got absolutely no bile, which is going through to the bowel itself, and all the patient's bile is draining outwards, either through a PTC or a wound drain, some patients will actually, they are able to actually drink some of that bile again afterwards, because losing your bile acid and your bile salt pool is actually quite deleterious to homeostasis. So if we keep patients in hospital, we pass a fine bore nasogastric tube and we will refeed the patient's bile through that. But I've had some patients who have actually been amenable to mixing it with something like Oros or a sweet concentrate, and then actually, will pinch their nose and actually swallow the bile, a few times a day, just to maintain, and negate against something like bacterial overgrowth. There's also the possibility, this was a publication from the UCT group about 2 or 3 years ago, where you can actually, in the interim period where bile needs to be controlled, you can use the PTC to introduce a catheter into the gap between the bile ducts. So what you do here is you do an ERCP, you introduce a guide wire into the bile duct, inject contrast, and then deploy a Dormia basket that you would use for stone extraction into that subhepatic space, and then try to introduce a guide wire through the PTC catheter into the vicinity of the Dormia basket, close the Dormia basket, and then pull the guide wire that has been introduced percutaneously into the duodenum, and then do a rendezvous ERCP to place something like a covered metal stent to actually bridge the gap between to cross the defect and to control that until the patient is either treated definitively with surgery, or in some cases possibly this could be a definitive repair, although that is expected to stricture afterwards. So in patients that need a hepaticojejunostomy, and hepaticojejunostomy is the gold standard repair, it can be done for most injuries that have occurred. So hepaticojejunostomy is the one that we fall back on as a definitive repair. These are challenging operations, and if they're done after a variable period, especially if they're done at 3 months or 6 weeks later, we expect that these will be difficult operations. And just to take you through the steps of a hepaticojejunostomy, let me just see how I'm doing for time here. So, okay, so we've still got a little bit of time just to quickly go through this. The first step is to find the bile duct injury. And in these patients, we use the subhepatic surfaces to guide us towards the area of injury. We expect the colon and the duodenum to adhere itself to this area or omentum. So we first dissect the way after an appropriate incision. We dissect the transverse colon or the right hepatic flexure of the colon away, and then follow the subhepatic surface from the left and the right side towards the area of injury. So we come in widely and cone into the area of injury. But during this dissection, a good landmark is obviously the old gallbladder bed, as well as the falciform fissure. If you follow the falciform fissure between segments 2 and 3 and segment 4 downwards, that would invariably bring you to the hepatoduodenal ligament. And what happens in these patients is that the area of scarring and fibrosis will obviously pull up the duodenum onto the clips or the site of injury, creating a false impression of the height of injury. So the duodenum should be dissected away very gently, usually with suction dissection or some very directed sharp dissection to uncover the old site of injury during that injury. So you can see that the gallbladder plane, as well as the falciform fissure, will guide one towards the area of injury. And that is what you see over here, keeping in mind that the bile duct is an anterior or a ventral structure within the hepatoduodenal ligament. We don't operate behind the bile duct in these operations because we don't try and expose the arteries or the portal vein. We're just looking for an area to repair, because any other dissection might compromise further blood supply to the bile duct area. And we only expose the other anatomy if we are totally lost and we need to see where we are. And quite often, the catheters that have been placed by PTC are very helpful in obviously finding the area, because that can be followed backwards into the ducts. But the gold standard repair, the hepaticojejunostomy, is done by the so-called Hepquineau technique. which is really what we aim to repair patients on the left hepatic duct, because that is an extra hepatic, the left hepatic duct, once the common bile duct or the common hepatic duct is formed, it forms from a left hepatic duct that has a 2 to 4 centimeter course at the undersurface of the quadrate lobe or the segment 4 base, from which where it is easy to find extra length for an anastomosis. So this area here is what is commonly referred to as dissecting the hilar plate. But I think in effect, because segment 4 always comes to attach itself to the area of injury, just some blunt dissection with the suction instrument is usually what we would describe as lowering of the hilar plate. But the true lowering of the hilar plate implies that you open the Glissonian sheath a little bit, and then what that helps is to ease some liver parenchyma off the duct so that this area can be exposed. So the suction instrument is very helpful to do this, and if you are lost and if the patient had a stricture, you can use some gentle aspiration as well in the expected area of the left bile duct to try and find the left bile duct to which you're going to anastomose to. And then eventually, once you've opened the duct a small bit, sequential sutures will then help you to expose the duct wider and wider for a wide repair. And I think we usually aim for at least 2 centimeters of duct to which to be able to do a repair. When it's in some patients, there will be some fusion of the left liver lobe as well as segment 4, and opening that up actually helps you to see the left duct much better as well. But when you follow the left hepatic duct towards that area to open more left hepatic duct for a wide anastomosis, just beware that the middle hepatic artery is a variation that crosses over the left bile duct to supply segment 4. And so when you've opened this, be cognizant of the fact that there might be a sudden arterial bleed if you dissect too far along the left hepatic duct, which will be the middle hepatic artery which has been opened up. So for patients that have an intact confluence, even if there is some common hepatic duct, the repair should still be done into the left hepatic duct, because we rely on the left hepatic duct to actually drain the confluence. The right hepatic duct drains into the confluence, into the left. And if you can do a wide anastomosis in a patient with E1, 2, and 3 injuries, it would be representative of the whole liver. So that is really the standard technique. But patients who have E4 or sometimes E5 injuries, it might be necessary to do separate anastomosis because the ducts have actually been separated and they don't communicate to each other anymore. And in these patients, it becomes important to then also gain length on the right side of ducts. What makes the repair sometimes easier is to suture the left and the right ducts together posteriorly. Or then if it's possible, if there's too much of a tissue gap, then you will have to do a separate anastomosis to the left and to the right ducts. To gain length on the right sided duct, you would first expose the left sided duct as for a Hep Quinault approach, and then in the coronal plane, then by following the coronal plane on the left duct towards the right, that would bring you into an area where the old cystic plate was, and if you follow that area, you will encounter some scar tissue over here. And by working over something like a right-angled Leahy or a go-around type of dissector, you would then be able to follow the plane over that duct and open up enough space to be able to expose the right hepatic duct. And in some patients, it might be even appropriate to, with a CUSA or with a bipolar, try to take some tissue away so that you can gain length on the right hepatic duct. But these are repairs really for experienced surgeons. And once you have exposed these areas, should you use a transanastomotic stent? So if you have a pre-existing percutaneous transhepatic biliary drainage catheter, then you will place that across the anastomosis so that you can do a cholangiogram afterwards before you remove the catheters. But if there was no PTC done before, so you have a fit patient who has been discovered in the 4th or the 5th post-operative day, you don't always need a PTC in those patients. But once you've made the anastomosis, if the ducts are actually smaller than 4 millimeters, you could attempt a retrograde percutaneous silastic tube placement with a sharpened guide wire under cholangiography to then stent your anastomosis if the ducts that you worked on are hypoplastic or very small, or you weren't able to gain a lot of length. In some patients, a liver resection might be appropriate, but if we think about liver resections during bile duct injury, in the immediate phase, in patients who've had vascular injuries, if there has also been a portal vein injury, these patients will have fulminant hepatitis afterwards or ischemic liver injury. And these patients, you might have to even do a liver transplant if there's been a lot of hepatic necrosis. But if the right hepatic artery and right portal vein have been injured, then in these patients, you would consider an early hepatic resection. Whereas in most patients, it's the right-sided bile ducts that can't be incorporated into an anastomosis. And in some patients, a right hepatectomy would be considered, but invariably, the right hepatectomy is reserved for patients where a repair was attempted, and then it strictures, and then a few months down the line, the patient has unreconstructible anatomy where liver transplantation would be entertained. Lately, there has been some, renewed interest in performing end-to-end repairs for patients that have had interruption of the bile duct. But historically, these end-to-end repairs have had a failure rate of up to 80%. And if you think about this, there are very few patients where you can repair a bile duct injury at the index cholecystectomy with an end-to-end anastomosis. These are mostly done for low injuries, where patients with a Roux-en-Y would have a good outcome anyway. But it is possible to do an end-to-end repair in patients where you have had an early detection, there's absolutely no sepsis, minimal inflammation, there should be no tissue loss, so there should be no tension in the repair. There should have been no thermal injury because you might be repairing an area that is actually injured and is expected to actually die or stricture afterwards. No arterial injury. The CVD should be more than 4 millimeters diameter, and you should probably add a stent to that repair. So in essence, it's not a direct competitor to hepaticojejunostomy because the patients on which you can do an end-to-end repair is actually a very, very small fragment of patients or patient cohort. But the proponents maintain that this is physiological. You maintain endoscopic access. Complications can be addressed percutaneously or endoscopically. And you could always, if the repair fails months or years down the line, still go and do a Roux-en-Y hepaticojejunostomy later on. But in some case series, it has been shown that you can expect 91% stricture-free survival. However, if you look at this very large series that was published in 2007 in 57 patients with the end-to-end anastomosis, 2/3 required an endoscopic intervention, and eventually a third of the group required hepaticojejunostomy. I suppose one way to look at this is also to say that 2/3 of patients have been spared hepaticojejunostomy. But on the other hand, patients with a HepJej, if done in experienced hands, have an extremely good outcome with a less than 10% stricture, long-term stricture rate. So the gold standard really still is to do a hepaticojejunostomy for major bile duct injury. Okay, so thank you for your attention. That bile duct injury is a very big topic for a short tutorial, but I just tried to highlight that it remains a big problem, that we should do everything in our power to avoid it, recognize it early, follow the steps, and once you have classified the patient, your options are endoscopic or open repair by hepaticojejunostomy as appropriate. Thank you very much. So we'll see whether, so I'm going to just see if there are any questions to answer. You're welcome to turn your mics on, put your hands up and ask questions directly. Let's have a look here on the chat. Okay, something about clarifying. Thanks for clarifying immediate or small bowel injuries. and still proceed to repair lap or open. Okay, so that's from Muaz. Thanks for the immediate repair for small injuries like a D. Yeah, so a small injury like a D injury, these can be repaired laparoscopically if you have the laparoscopic skill. If it's not thermal, if it's not a large defect, 1 or 2 stitches with a very fine absorbable suture, and then place a drain over the repair. The other way would be to put a T-tube in, but a T-tube in really is not, it's not a great way to fix a small injury because it tends to enlarge the injury. So we try and steer away from T-tubes and either just put in 1 or 2 small absorbable sutures, put a drain over it, and then consider an ERCP afterwards to place a stent if that repair does start leaking. And usually in these patients where you've done a Strasbourg D attempted repair, if we're going to do an ERCP afterwards for these patients, we would aim to get in as many stents, plastic stents, in the first ERCP, not just 1 stent, but try to get in 2 8.5 French stents or maybe 3 7s, so that you have a bit of a framework around which the bile duct can heal much wider. I try to still stay away from putting in a covered metal stent in these patients. We don't have any direct comparisons as to which would be better, but with a plastic stent placed for a D, you can get the patient back, after 1 month and 2 months, and try and put in quite a few stents, the kind of the Costamagna type of technique, and then again try and remove them after 6 months and see whether you are left with a stricture or not. The next question is whether I have any experience with hepaticojejunostomy versus hepaticojejunostomy. So there have actually been some very good studies. There's one paper that was called for bile duct repair, use the duodenum. It's right there. It was published in the Journal of the American Association of Surgery. And in those enthusiastic groups, hepaticojejunostomy can have a very good outcome, especially in patients where, for instance, the abdomen is frozen and you're not able to get a hepaticojejunostomy up to the site of repair. However, the duodenum for a direct colodocus to duodenum repair, usually it implies that this is quite a low injury. There's no way that you're going to suture the duodenum to an E3, E4, E5 injury. In those patients, it just isn't considered. So really, you're looking at an E1 patient where you can mobilize a little bit of duct and suture it directly to the duodenum. But I think as an exam answer and as a default, talking about gold standards, the hepaticojejunostomy is still favored over a hepaticoduodenostomy. Hepaticoduodenostomy, you could also put a stent through that you could obviously remove afterwards by ERCP. So there are some benefits to trying to do a hepaticoduodenostomy, but a HepJej remains the favored approach. Okay, so I don't see any other questions. That's it from my side. Is there anybody else with a question or with a hand up? Thanks everybody for joining. I see we have about 15 or 16 people that joined today. All right, so the recording will be available and published on the Gecko website. So just from my side, thanks to the ECHO team at the University of New Mexico and for the ECHO India team as well for supporting us today. And thanks for those of you who actually tuned in today. And I'm not sure what the topic is next week, but please be sure to join in again on the 17th when the next installment will be broadcast. Thank you very much. Karen, over to you. Is there anything else from your side?
Thanks very much, Stefan, for that. Appreciate it. And I don't have a topic for next week quite confirmed yet, but I'll let you all know on email. Thanks, everyone. Bye now.
Cheers. Bye-bye.